Hello everyone, welcome back. Today we're going to be talking about cocaine and amphetamines, and you can find this information in chapter 7 from your book called Julian's Primer of Drug Action. There will be two parts to this lecture. The first part will cover cocaine, and the second part will cover ephedrine and methamphetamine. So let's start with part 1. We're going to talk about what cocaine is, what the ADME, and if you remember, ADME stands for administration, distribution, metabolism, and excretion of the drug is. So this is the how long the drug lasts in the body and how effective it is. We'll also talk about the pharmacokinetics, which is covering the way that the drug influences the brain and the molecules of the brain. And so we'll look at it from that aspect. And we'll also talk about the effects of cocaine, the physiological and the psychological, and also the treatments that are offered for drug abuse. So cocaine is considered a psychostimulant, and as we've learned before, stimulants are the ones that wake you up, they make you feel aroused, and so psychostimulants like cocaine activate the transmitters that stimulate the sympathetic nervous system and mimic sympathetic arousal. So if you remember, the sympathetic nervous system is involved in the flight or fight. And so kind of like when an animal is faced with, let's say, a predator, is it going to fight off the predator or run away? But regardless of what it does, it needs a lot of energy to be able to do that decision. And so a stimulant, kind of mimics that whole, needing energy to be able to do whatever job or function that it is that you need to do. And so that's why it's considered something of arousal. So it also causes a rush of dopamine into the brain's reward pathway, which is not surprising because we've mentioned before that pretty much all of the addictive type of drugs in one way or another manipulate the reward pathway. And so definitely cocaine does that. And it's also known that repeated cocaine use causes the brain to stop producing dopamine naturally. And so think about what would happen if your own brain stopped producing dopamine because it was so dependent on something else that was providing dopamine for it. What do you think would happen to your mood if your brain wasn't producing that much dopamine anymore? If you said that, your mood would go down, like for example, you would feel more sad or depressed, you are correct because dopamine is that feel-good chemical. And so if your brain is not producing it, then you're going to feel the opposite of feeling good. Let's talk about the history of cocaine. And so around 5,000 years ago, the early indigenous civilization from South America found value in the cocaine plant, which is called erythroxylin coca plant. And this is also found grown in the jungles of Peru, Bolivia, and Colombia. Indigenous people they still do. They used to, and they still chew on the leaves for nutritional value and for its stimulant and analgesic effects. Now, chewing on the leaves of the coca plant does not give you the same effect as like snorting it, like a really high dose, just because there's a very low dose in the leaves themselves, and it's also slow releasing, and so you don't have the same effect as if you do, with cocaine that's actually been purified and extracted from the leaf. In the 1700s, when the Spanish conquistadores visited South America, and they saw the indigenous people chewing on the coca leaf, at first they tried to ban it, but then they noticed that it increased the work capacity of the Indians. And so they actually introduced it back to Europe, so they took it back with them, and that's how the knowledge of the cocaine or the coca plant became more widespread. In 1800s, the actual molecule cocaine was isolated, and so this is what the molecule looks like. And if you notice, it has a lipophilic pocket, meaning that it is lipid soluble, and that also means that it's nonpolar, and so it has a very good nonpolar region. And if you remember, what do nonpolar molecules do when it comes to our cell membranes? Like, can they easily diffuse through, or do they have a hard time going through our cell membrane? If you said they can easily diffuse through, you are correct because our cell membranes are also nonpolar. And so nonpolar interacts with nonpolar. And given that this is a pretty small molecule, it doesn't have too much of a hard time getting into the cell membranes of our tissues and our brain. In the late 1800s, there was medicinal use for cocaine, and it was used to treat depression, fatigue, and also used as an anesthetic. And so an anesthetic is a way to like numb an area. Like by numbing it, what numbing means is that you remove the pain. And so an anesthetic is good for surgery, for example, so that way you won't feel the pain of the incision. And one of the doctors that first discovered that cocaine was good for that was a doctor. I forgot his name, but it was during these times, and he was known to do surgeries on the eye, except that his patients couldn't withstand them because it was so painful. And when he used cocaine as a topical, he noticed that he could do these surgeries with much more ease, and his patients didn't feel the pain of the surgery, and so that's how cocaine was also discovered as an anesthetic. Back in the late 1800s, there was cocaine in the soda, and that's why it was called Coca-Cola, so it comes from the coca plant. And so the first bottle of Coca-Cola made in 1894 had 3.5 grams of cocaine in it. And so this was basically one of the most popular soft drinks, and it still is to this day, except that we, of course, don't have cocaine in our Coca-Cola. However, soda is still very addicting. Like it still tastes very good, and then it makes you want to drink more. So I wonder what the ingredients are in soda that makes a person want to always drink it. Back in the day, when a person drank Coca-Cola, the effects were euphoric and energizing, and it helped the consumer. Or it helped the people who sold this skyrocket in popularity. And so that's why it's been so popular since the late 1800s. Which reminds me to one of my favorite memes that made me laugh when I first read it. And so here's a little girl, and she said, "Grandma said in her day she did 3 times the work you do today." And so the mom responds, "In Grandma's day they had cocaine in the sodas," which is true, right? All right, cocaine history to be continued. And so the Harrison Narcotic Act in 1914 banned the incorporation of cocaine into patent medicines and beverages, and then cocaine disappeared until the 1960s. And that's because, they started noticing that cocaine was a very addictive substance, and, it also had its negative side effects. And so they figured, they had to regulate how cocaine is being distributed. In 1912, the United States government reported 5,000 cocaine-related deaths in 1 year, and by 1922, the drug was officially banned. During the 1970s and 1980s, more people could afford cocaine, and the new epidemic of cocaine users began. I don't know if any of you have ever watched Scarface, but cocaine just reminds me of Scarface. I really liked that movie. I thought it was pretty good. And so it became a popular drug among new entertainers, like for the entertainment business and for business people. And traditionally, cocaine was a rich man's drug due to the large expense of the cocaine habit, just because a person needs to use it often just to feel that high. In the early 1990s, the Colombian drug cartels produced and exported around 500 to 800 tons of cocaine a year. And as of 2008, cocaine had become the second most trafficked illegal drug in the world. There are various types of cocaine, or forms of cocaine. And so the first one that we learned about came from the leaf chewing. And so this is from the leaf coca. And this produces about 1% of cocaine. And so that's why I said that if you chew it, it doesn't give you that strong stimulant effect as you would if you had the cocaine powder. And so the cocaine powder is basically the cocaine that was first extracted from the leaf coca and then multiplied in the lab. And so, you can make this in the lab and you can make it really highly concentrated. And so now the concentration can come, from 25 milligrams to 50 to 100 milligrams. And so some individuals snort it and others ingest it. And there's also freebase crack cocaine. And crack cocaine is basically a mixture of cocaine with baking soda and water. And so the milligram is higher in this case, and it is heated and inhaled. So there's different ways of taking the cocaine depending on how you get it. Let's talk about the pharmacokinetics. And so the pharmacokinetics are the absorption, distribution, the metabolism, and excretion. So let's start with absorption. And so it can be snorted. And if it's snorted, then the effects are felt within 5 minutes because it enters the bloodstream really quickly. However, only 20 to 30% is absorbed into the mucous membranes, meaning that the rest of it is just, passed on, like excreted from your body. And if it is smoked, it takes about 5 minutes to reach a peak. Reaching a peak means that you can feel the effect at the maximum. And so that takes about 5 minutes. And again, just like how it's being snorted, the smoking effect only absorbs about 20 to 30% of the drug. When it is injected, and I'm talking about intravenous injection, so this is straight to the vein, 100% of the drug is immediately absorbed into the body, and so none of it is lost because it is in the bloodstream at this point. And it takes around 30 to 60 seconds to feel the effect. And the reason why there's a little bit of a time delay is because it just takes some time to reach the brain. And people are interested in the psychostimulant effect and the effect that it has on the brain. And so it takes a little bit of time to reach there, but it is felt immediately. And the person receives the entire dose. And so this is why taking drugs by injection is the most dangerous way of taking drugs, because it doesn't give your body enough time to react if you experience an overdose. So although the person can feel it immediately, they also run the risk of overdosing. And it can also be ingested, and if it's ingested, because it goes through the digestive system, the peak in which the person feels a high can take anywhere from 30 minutes to a little bit longer. And the body also only absorbs about 20 to 30% of the total drug. Now, once it is in the bloodstream, it penetrates the brain rapidly, and higher concentrations are found in the brain than in the rest of the body. And so it tends to stay in the brain more. And it can also be distributed to other tissues in the body, and it freely crosses the placental barrier. So if you remember what the placental barrier is, this is found in pregnant women, meaning that the baby will also feel the effects of the cocaine if a pregnant woman takes it. The metabolism of cocaine is in the liver, so that's not surprising because that's where the majority of metabolism occurs. And the metabolism and excretion of cocaine takes about double of what 50 minutes are, so that means 100 minutes. 50 minutes is basically the biological half-life, meaning that half of the cocaine is gone, from the time the person ingests it. It takes 50 minutes for the body to get rid of the cocaine, meaning that the enzymes are breaking it down, and after 50 minutes, only half of the drug that was first injected or absorbed or however it was taken is gone. The enzyme called butyrylcholinesterase is the enzyme responsible for breaking down cocaine into a metabolite. And once the cocaine is into a metabolite, then the metabolite no longer affects the body in a similar way that the cocaine does. And then that can be excreted through the urine. Now, there's a different type of metabolite called cocaethylene. And so cocaethylene is basically a metabolite made when a person drinks alcohol, so ethyl alcohol, and takes cocaine. And so what's interesting is that this metabolite here called cocaethylene, it's actually even more potent than the cocaine itself. And so the cocaethylene becomes even stronger, and so the person feels the effect very stronger. So if they mix alcohol with cocaine, the effect is that much more intense because of the metabolite that is produced. And overall, the metabolites, once it's broken down, are excreted through the urine. And this right here, this molecule here called benzoyl econine. Sorry, I'm horrible at pronouncing these. These can be kind of hard. So this metabolite right here is the one that is detected in urine, and it can stay in urine up to 48 hours after a person uses the drug. And it says here it can stay in the hair for quite a bit of time too. Okay. Let's talk about the mechanisms of action of cocaine. There are three prominent pharmacological actions that account for virtually all cocaine physiological and psychological effects. It works as a psychostimulant, as a vasoconstrictor, and also as a local anesthetic. So let's start off with cocaine as a psychostimulant. And so this is how it affects the brain and the neurons. And so if you remember these structures, this here is a neuron. And these structures right here, these are uptake transporters. So this is basically a protein, okay? So this is a protein and this is a protein here. This one's acting as an uptake transporter, meaning that the neurotransmitter that is in the synaptic cleft, and so this is the synaptic cleft, the neurotransmitter is recycled by going back into the transporter, and then it is put in a vesicle, and then it is dropped off, to the synaptic cleft. And so that is the job of the transporter, is basically to recycle and lessen the concentration of whatever neurotransmitter is in the synaptic cleft. And the receptor, so in this case, this is a dopamine receptor. The receptors are the ones that are like antennas to a TV, receiving signals. And so receptors are the ones that receive the signals from the neurotransmitter. And once a neurotransmitter binds, then it tells the postsynaptic neuron what to do. So either it'll tell the neuron to fire even more, and if it's firing more, it's stimulating it, or it'll tell it to slow down. So if the neurons slow down, then it's being relaxed. And so what cocaine does is it blocks the uptake transporter. And so if you have cocaine here blocking the uptake of dopamine, okay, so that means dopamine can get through, it can't be recycled. What do you think happens to the concentration of dopamine at the synaptic cleft? Does it increase or does it decrease? And if you said increase, you are correct. So if you block the transporter, that means that dopamine can be recycled, and a whole bunch of dopamine remains here in the synaptic cleft. And if you have a lot of dopamine hanging out, that means that you have a lot of dopamine stimulating neurons, and it's just activating the reward pathway, and so it's stimulating it. Okay, and so that's how cocaine works. And if you remember on the last exam for the extra credit, I asked you what would happen if you inhibit the MAO enzyme, and the MAO enzyme is basically an enzyme that breaks down dopamine. If you inhibit that enzyme, meaning that you stop that enzyme from breaking down dopamine, then you end up with a whole bunch of dopamine at the synaptic cleft, and it'll stimulate, the neurons that are related to the reward pathway. And so MAO inhibitors are used also to treat depression. So this is just to reiterate what I just said. And so the action of cocaine, this is a normal synapse, and so this is the, just like a normal amount of dopamine hanging out at the synaptic cleft. And once cocaine is taken, what it's doing is that it's blocking the uptake of cocaine, and now that it can't be recycled, you end up with a higher concentration here at the synaptic cleft, and now it's just stimulating the neurons even more, okay? All right, let's talk about cocaine, as an anesthetic. And so an anesthetic means that it numbs the area in which it is placed. And so this is actually for a local anesthetic, and it is used legally by doctors, especially during surgery. And it is applied to certain areas of the body, for example, the nose and the mouth, to cause the feeling of numbness, and that way you don't feel the pain. And this allows certain kinds of procedures or surgery to be done without causing pain. And so what cocaine does is it basically blocks the sodium channels. And so this is not, the blocking is the same thing like how the blocking is done in your brain. But remember, the blocking is done to the channels that are in other areas of your body. And so it's not activating the reward pathway in this case. But by blocking the channels, it doesn't allow sodium to enter. And that means that if sodium doesn't enter to create that gradient that neurons need to fire, if it's not creating the right charges, and so this is the easiest way I can put it, okay? So if it's not generating that charge of positive and negative outside and inside of the membrane, then the neurons can't fire. And so this affects the pain sensory neurons. So if the pain sensory neurons are basically being blocked, that means that you won't send pain signals to your brain. Okay? And so that's why it works as a local anesthetic, because cocaine blocks the sodium channels, and the sodium is very important for the action potentials, or for neurons to generate action potentials. If it blocks sodium from entering, then neurons are not generating as many action potentials as they normally do. And it's a great way to block the neurons that activate the pain signals. And so when cocaine, wasn't necessarily too restricted in the early 19th century, it was used as a local anesthetic. And here is like a label here in which cocaine was used as a like for mouth pain. So this is a toothache drops, and you could just purchase it for 15 cents. Cocaine is also known to be a vasoconstrictor. So vaso meaning like your blood vessels, constrictor meaning to constrict, to tighten. And so what it does is that it narrows down the tunnel in your blood vessels. And so this right here decreases the blood flow. And if your blood flow slows down, it makes your heart work harder. And so it makes your heart pump more. And it creates pressure in your heart. And so this can be used as a medicine to help people who have low blood pressure. So if a person has low blood pressure and they need to raise their blood pressure, then this is a great way to raise it. And also this whole thing of slowing down blood flow, it's also good for individuals who are excessively bleeding. And so let's say you just you just got an injury, and you need to stop the blood from just releasing. If you vasoconstrict, then blood flow slows down, and so by blood flow slowing down, you don't have as much blood loss. All right, let's talk about the physiological effects of cocaine use. The physiological effects are various, and so it can cause an increased heart rate, increase in blood pressure, increase in body temperature. It could slow down blood flow, and can also cause an individual to feel like they have more energy, and they can feel more alert. And it also causes pupil dilation, and so people who take it may have like really big pupils. It also decreases an individual's fatigue and appetite, and so it's been used as a appetite suppressant. It also increases the activity and libido, and also prevents sleep and creates general feelings of euphoria. And so euphoria is like happiness, that feeling of happiness. The duration, the part of the positive feelings, can last anywhere from 10 to 20 minutes. And then after that is the come down. And when a person feels the come down effect, which means that the dopamine is no longer being overly stimulated, or the dopamine neurons are no longer feeling overly stimulated, then they can feel the opposite effect of the positive feelings. And so as the drug is being metabolized and, excreted from the body, then a person can start feeling depressed right after that positive feeling. They'll have that let down or come down feeling of like depressed and sad. And this is why people actually try to take more cocaine, basically, to avoid the come down effect of cocaine. They want to feel that upper feeling that they first felt. And in this case, as you can imagine, you can develop really easily tolerance. So it's rapid development of tolerance with continuous use. And it has a lot to do also with this come down feeling here. And it may cause switch from intranasal to inhalation or injection. And a person will switch because injection or inhalation, you can get that into your body a little bit quicker. And so it just creates a person to use cocaine in a different way and to obtain it in higher doses. Now let's talk about the physiological effects of increased cocaine, meaning just chronic use of cocaine. So this is using cocaine over long periods of time. And so this intensifies the effects of high blood pressure levels, increased impulsivity, anxiety, and also starts to develop paranoia symptoms. And so some people can develop paranoid schizophrenia, meaning that they'll hear things and see things that are not there. They're more likely to do compulsive behaviors. And so compulsive means that you don't think about it, you just do it. And so let's say you're about to fight somebody, you may not think about it, you might just go for it. Also increases hallucinations and in some people sexual dysfunction, meaning that they can't have sex because they just don't feel the need for it, or dysfunction in that for males they can become more impotent. Also increases the prevalence of cardiac damage with heavy use, and this is also one of the single greatest cause of premature death on chronic users, is that it basically affects the heart. And again, that's because the heart has to work so much harder to pump blood because of the vasoconstricting effect of cocaine. And there's also brain changes, and so this is loss of gray matter. And so there's white matter and gray matter that make up your brain, and losing any type of brain cells, of course, can have an effect on how you behave and just overall how you feel. And so long-term use of cocaine can cause the brain to actually shrink and for you to lose neurons, and also to have abnormal neural responses in the cortical areas, and dopamine deficiency, and also a decrease in cognitive functions. And so people, who are chronic users can, over time, develop they can lose motivation and not want to do anything other than obtain cocaine. Withdrawal symptoms can be pretty intense, and if you remember, withdrawal is when a person just suddenly stops taking the drug, and this is for chronic users. So withdrawal symptoms can be depression, which is not surprising because now your body is depending on cocaine to obtain more dopamine than for your brain to make the dopamine itself. And it can cause dysphoria, anxiety, somnolence means that you'll just stay up, you won't sleep, drug cravings, and sexual impact. So a person can't perform because there's not enough blood flow, going on to the important areas for you to perform. There are treatments for cocaine use, and treatment for cocaine addiction typically involves detox and therapy. So detox means that, a person slowly stops using the drug, and therapy is just basically seeing a therapist. And so this can be done in inpatient rehabilitation programs. And but there is no medications for treatment. So if you remember when we talked about other types of drugs, a person can also take pharmaceuticals to help them overcome addiction, and some can be agonists. And agonists are the ones that basically mimic the drug. And then there's antagonists, which basically block the drug from having an effect. But in this case, there could be something now. I haven't done the research as of today, but according to the textbook, there are currently no medications for treatment. All right, let's talk about part 2, which is the amphetamines. And so we'll cover what amphetamines and methamphetamines are, the anatomy, the pharmacokinetics, and the effects and treatments. An amphetamine is also a central nervous stimulant that is used in ADHD type of disorders. And so ADHD is attention deficit hyperactivity disorder. And so it actually helps a person calm down, a person who's feeling hyper, and it helps them become more focused. It also helps with narcolepsy, and so these are people who can't control when they fall asleep, and also used for obesity, and so it can be just basically an appetite suppressor. Amphetamine molecule has 2 isomers, and so it has dextroamphetamine and D-amphetamine, and so these are the 2 isomers. Isomers mean that they are identical molecules, except that one is left-handed and the other one is right-handed. And so they can have different effects just because they have different orientations in space. The drug Adderall to treat ADHD actually has a combination of both of these isomers, to not make it as strong, but yet both of these still have the same effect on the body, but you just don't have as strong of an effect if you would just be taking one type of isomer. Let's take a look at the amphetamine structure. And so amphetamine, this is what it looks like. This is the molecule. And if you look at the other molecules, methamphetamine, 1 plus 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 dopamine, norepinephrine, and epinephrine, you'll notice that it has very close similarity to all of these molecules, which is the reason why these molecules, amphetamine and methamphetamine, are so successful. That's because they mimic, and if you remember that name, mimic, to copy, that's because they mimic the already naturally occurring neurotransmitters that the brain makes. Okay? And so that's why they're able to manipulate and hijack our brain cells and cause us to have changed behaviors simply because they look so similar to these other naturally occurring neurotransmitters. In the late 1880s, ephedrine was isolated from the stems of the ephedra plant and then synthesized. And then from ephedrine, amphetamine and methamphetamine was synthesized. And so that's where we get amphetamine and methamphetamine. It actually comes from ephedrine, and that comes from the ephedra plant. In 1924, the effect similar to transmitter epinephrine was used for asthma. And so this drug here, epinephrine, can treat people who have a hard time breathing because it can open up the bronchioles. And so ephedrine at that time was a great way to treat asthma because it can be taken orally and was much longer lasting. And so in 1934, it was used in inhalers. But because, of the other effects that ephedrine has, this type of drug was easily abused. Okay, and so people just would claim that they have asthma all the time, but they just wanted the effect of the amphetamine. In 1937, doctors and just individuals noticed that there is also another interesting effect of amphetamines, like ephedrine. It had a calming effect on hyperactive children, and so these are individuals that have really high energy. It actually calmed them down, which is the opposite of what it does for people who do not have a hyperactive disorder. It basically stimulates them and brings their energy up. And so it was just interesting that it produced this calming effect in really hyperactive children. And that's why this drug is used in like ADHD medication, it's used in Ritalin to treat ADHD. And it was also prescribed for weight reduction because it dramatically decreases a person's appetite. During World War II, the armed forces of many countries issued amphetamine to overcome fatigue, and so that kept soldiers up for longer periods of time and kept them more alert. After the war, amphetamine was used inappropriately for weight control and depression, and then in the late 1970s, the epidemic begins to recede. And so government put legal pressure on drug companies to decrease production, and medical use was inhibited and unethical physicians were prosecuted. And so basically doctors were just prescribing this, like candy, not really paying attention to whether the individual really needed it. Probably because, they make a profit off of it, and so they had no problem prescribing it. Especially if you have an addictive behavior towards it, you're going to, want to buy this all the time, so you're going to want to see a doctor all the time to get a prescription. And so eventually other medical alternatives were made to overcome depression and basically become the drug of choice instead of using amphetamine or methamphetamine to treat depression because, of their addictive properties. Today, there is a concern about prescription stimulant abuse, and this is especially true for college students and youth. And I have a little story on this, and so I'm just telling the story. I am in no way judging anyone, and I am in no way judging people who have ADHD. But I had a friend when I was in college who we used to study together, and we were both at that time interested in becoming pharmacists, and so we were just basically taking the same classes together, getting our prerequisites done so that we can go into pharmacy school. And I always wondered why she had the ability to study like all night long, all the time. She could do this all the time. She had a great way, like she always like memorized stuff really well, and she just studied every day for like 8 hours. And I couldn't, like for the life of me, like I couldn't like stay up that long. I had like, I would get fatigued really easily. I didn't have that type of patience. And I found out later that she was abusing Ritalin. And so Ritalin is to treat ADHD. So she was basically getting prescriptions and abusing it. She didn't have ADHD. And yeah, that's how I found out how she did so wonderfully in school. And and as I, continued getting my graduate degree, I realized that college students indeed were using this, to help them study. And so it doesn't surprise me that this has been an increasing epidemic among college students. And so there's a certain type of drug, this drug called Vyvanase, which is approved by the FDA for treating binge eating disorder. And remember, we said that amphetamines cause a decrease in appetite. And so people who are binge eaters, and so binge eating means that you're overly eating and then you puke, you throw it up. But I mean, we're talking about these people who have like big feasts. They have a lot of food and they throw it up because they don't want to gain weight, and then it becomes a disorder. So Vyvanase was created so that people can decrease basically their appetite and prevent them from binge eating. And it has been approved for ADHD treatment as well, meaning that you can find amphetamines in ADHD type of drugs. All right, let's talk about the mechanisms of action of amphetamine. In low doses, amphetamine binds to the presynaptic membrane of dopaminergic neurons. So these are neurons that have dopamine, and induces the release of dopamine from the nerve terminal. Well, that's not surprising, right? And it also binds to the dopamine reuptake transporter. And so this is the same thing as how cocaine works, causing it to block the reuptake of dopamine and allowing more dopamine to be available at the synaptic cleft. So this is in low doses. In high doses, amphetamine not only blocks the reuptake transporter, but it also binds to the monoamine oxidase, remember MAO, to prevent the enzymes from breaking down the dopamine, to prevent them from degrading. And so now you have the effect of the amphetamine blocking the enzyme that breaks down dopamine and also blocking the reuptake. So you can imagine that in this case, there's even more dopamine hanging out in the synaptic cleft. And interestingly, it also interacts with the synaptic storage vesicles that release free dopamine in the nerve terminal of the synapse. But this information is questioned. But if that's the case, so let's take a look at it. If that's the case, then that means that you have amphetamines acting in every single part of the neuron that prevents the enzymes and the neuron from removing dopamine from the synaptic cleft. And so you have amphetamines blocking dopamine transporters. So if you block here, that means that dopamine can go back in. And you also have amphetamines blocking the enzymes, which would be out here in the synaptic cleft. I don't have a picture here. But the enzymes would be hanging out here, ready to break down the dopamine. But then you have the amphetamine blocking that enzyme from doing that job. And then you also have amphetamines messing basically with the vesicles that carry the dopamine and probably causing it to dock onto the synapse and release dopamine even faster. And so if you have all of these three things going on, you can imagine that amphetamine is a much potent, a much stronger stimulant than cocaine is. And so amphetamine, so let's compare cocaine and amphetamine. So amphetamine has a longer duration of effect. The half-life can be in hours or like even 11 hours, later. And so some people are known, like people who take meth, the methamphetamine, they're known to like not sleep at all at night because of how strong this drug is. And we saw how strong it is because of how many different ways it can block dopamine from being broken down. And cocaine has a shorter half-life just because of the way that it acts in the neuron. It's only blocking the uptake transporter, so it's not completely blocking every type of way to prevent dopamine from degrading. And so cocaine has a shorter half-life of 30 to 90 minutes in comparison to an amphetamine. And it's also metabolized a lot quicker. Okay, so the plasma and liver enzymes break it down much faster than amphetamine. All right, let's talk about low doses of amphetamine. So, pharmacological effects of low doses. It can increase blood pressure and heart rate, which is not surprising. It can relax bronchial muscles, and so by relaxing them, it makes it easier to breathe, which is why it's used in asthma medications. And it can stimulate the central nervous system, meaning that it can make a person feel awake. And this is a person who does not have a hyperactive, attention hyperactive disorder. And so these are for calm individuals. Well, not calm, but these are for individuals that just don't have that type of disorder, because it actually has, like we mentioned earlier, the opposite effect for people who are too energetic, which I find really interesting, and I really don't know how that works. Some subjective effects related to personality traits, which wouldn't surprise me if it affects your personality. In moderate doses, like 20 to 50 milligrams, which is often taken intravenously, the additional effects can be respiration stimulation, slight tremors, and so a person begins to shake, restlessness and motor activity changes, and so the way they move around, walk around can change. Maybe there's more jerking motions, or maybe a person can just run faster or do things faster. I'm not sure. As doses increase, the anxiety disorders also increase, and an individual can develop dopamine system dysfunction. And so if your brain is dependent on a drug to create more, and it's not creating more dopamine, but allow more dopamine to stimulate the neurons, then it sends a feedback signal to the brain to stop making dopamine. It tells the brain, like, hey, you don't need to make that much dopamine anymore because there's plenty of dopamine hanging out. And so that's only when the individual is taking the drug. But remember, if they're taking the drug every single day, the brain starts getting this feedback that says, stop making dopamine, stop making so much dopamine. And imagine if a person just stops taking the drug and their brain is also not producing the amount of dopamine that it should, that can cause a person to feel really depressed. And so that's that come down feeling. Let's talk about chronic doses and the pharmacological effects. So chronic means prolonged use over a long period of time. So some of these additional effects can be behavior outbursts. So it can be a person who easily angers, who just is erratic. They don't know how to control their behavior. It can also cause like a OCD type of behavior, so repetitive actions, an increase in weight loss, and so you'll see individuals very skinny. I did have a friend who was addicted to methamphetamines, basically the majority part of her life, and so I actually knew this friend since first grade, so I knew her for a really, really long time. And then around 16 or 17 years old, she started taking meth, and she never stopped. She just, when she was introduced to it, she did it for the rest of her life. And less than a year ago, she passed away. And to be honest, I'm surprised she lived this long just because of how addicted she was. But yeah, she passed away not too long ago from just drug overuse, and her liver just gave up on her. But she had all kinds of unfortunate side effects from it. She lost a lot of her friends. She lost her kids because she wasn't able to take care of them. And so, all of these really sad things that happened to her. But yeah, I was surprised and not surprised when I heard about her passing recently, but it made me sad because she was a childhood friend and I knew her before the drugs, and she was my best friend for like first grade all the way up until I was in high school. So I knew her for a very long time. All right, anyway, but I did see certain types of behaviors like in her, for example, the outbursts. She needed attention. She was just kind of, and this is after she was, doing it for a while, and I couldn't really develop a relationship with her because I didn't know how to, I guess I didn't know how to handle her personality. It was a little bit difficult for me. All right, toxic doses. So toxic doses are anywhere from 4 to 500 milligrams. And so we're talking about 20 to 30 milligrams is normally what people do. But, they increase the dose, especially if they inject it intravenously, because your body is absorbing the entire dose. And so toxic doses can vary. Severe reactions can occur. And in some cases, severe reactions can even occur with just low doses. And so it just depends on how well the body is adjusted to breaking it down. And chronic users tolerate larger doses. And so as a person uses it more and more and more, they need more and more to have the same effect. That's tolerance. And as an effect, it causes deterioration of mental and physical condition. And so that's not surprising at all. And so a person can lose weight, they can look fatigued, they can lose hair, it could cause them to look much older than they actually are. All right, let's talk about methamphetamine, which is similar to amphetamine, but it still has a little bit of a different effect. So about 35% of methamphetamine users in the United States got their methamphetamine from clandestine laboratories, which means secret labs. And basically, this is readily obtainable chemicals. For example, pseudoephedrine is mixed with the amphetamine. And that was interesting because, so pseudoephedrine is actually something that you can buy at the pharmacy to treat decongestion. So if you have like a lot of like boogers in your nose and you can't breathe well, you can actually buy pseudoephedrine. It's called Sudafed. If you've ever heard of Sudafed. But and a while ago, I used to work in a pharmacy, so I was a pharmacy technician because at the time I was considering becoming a pharmacist, but I ended up being a scientist instead. But anyway, when I was working at a pharmacy, I noticed that people on a daily basis, and I mean a lot of people, would buy Sudafed. And it would be like one after the other after the other. I'd have like a line of 6 individuals buying Sudafed. One bought like 3 boxes. The next one bought like 3 or 4. The next one bought like 4 or 5. And I used to wonder, like, and this is before I knew about all of this, but I used to wonder, like, why are people buying Sudafed so much? And it wasn't long after that Sudafed became restricted, and so now you have to go to the pharmacy counter, you have to show your ID, and you're only allowed to buy 2 boxes for like every 60 days or something like that. They restricted it. And then I found out later that Sudafed was basically mixed with amphetamine to make meth, okay, to give it that stimulant effect. And so then it made sense to me why so many people were buying Sudafed. And it was sad because there was like pregnant women that I would sell it to. And for a while, like when I started catching on what people were doing, it kind of made me sad for them, or kind of made me not want to sell it to them. But legally, I can't just not sell it to them. But you know what? I'd see like pregnant women, and they're probably being used. They're probably being paid off by somebody. And all kinds of individuals just buying Sudafed like crazy. But now, I mean, after the regulations came in, I didn't see that many people buying it as much. So methamphetamine is a powerful stimulant. It can increase wakefulness, physical activity, and decrease appetite. And it has a huge a huge half-life, meaning that it takes 11 hours for your body to break it down so that you only have 50% of the dose left in your system. And so methamphetamine, is the one that's known for people to stay up all night. And that one friend that I told you about that had the problem, she would stay up for days. And I'm pretty sure the reason why she got addicted to it was because of the come down effect. Because she would tell me that. She would tell me she'd feel really crappy, or she felt really tired. And so, that just makes a person want to use so that they can not have to feel that depressive effect. All right, let's talk about the pharmacokinetics. And so the administration of meth is vaporized and inhaled in smoke when it's converted to crystalline form. It can also be snorted as well. And so, there are various forms of taking it. The distribution is basically once the meth is in the blood, it is distributed to all body tissues and the brain very easily. And so there's no, just because it's kind of nonpolar, the molecule, it doesn't really have to battle to get into these tissues. The metabolism is 60% of it at least is metabolized in the liver, and so what's not metabolized is just excreted to the urine, like in the unmetabolized format. And so, like I just said, the drug is excreted through the urines, and about 40% of it is unchanged. And so that means that when a person, is receiving a drug test, they can be tested for the actual methamphetamine itself and also for the metabolite of what the kidney breaks it down into. And so a small amount of this breakdown is amphetamine, which is the pharmacologically active metabolite. And so I'm just saying that when meth is broken down, one of the metabolites is amphetamine, and that's what makes it so potent. All right, let's talk about the neurotoxicity of meth. And so these are based on several studies. So Thompson and colleagues identified a link between chronic meth abuse and structural brain defects. And so they noticed a reduction in gray matter and an increase in white matter, which is interesting. So it reduced certain parts of the brain while it increased others. I wouldn't be surprised if it increased like the frontal lobe or it increased the areas of the reward pathway. That makes sense because it just basically causes a person to hyper focus on how to obtain the drug so that they can feel happy again. And they also noticed tissue loss in the hippocampus. And so if you have tissue loss here, that's the part of your brain that creates memories. And so that means that a person can have poor memory, as a result of using meth all the time. And it can also cause oxidative stress, genetically based transcription factors and glial cell activation, DNA damage, blood-brain barrier breakdown, and neuronal degeneration. And so this is basically like going through Alzheimer's. And so it could probably cause a person to go through Alzheimer's very early in their life. Also, brain hypothermia. So it just changes, you just have a major change in the temperature of the brain. And so, yeah, it can just, in other words, it can be very toxic. And that's what neural means, your brain cells, very toxic to your neurons, causing the person basically to age quicker, age faster. And so the tolerance and dependence of meth, tolerance is rapid in development. So rapid development of tolerance to euphoria. And so that means that a person doesn't feel as euphoric if they take the same dose, all the time. They have to increase their dose. And so higher and higher doses are required just to feel that euphoric feeling once again. Drug use and withdrawal cycle may occur. And so a person may stop using the drug, but because of the negative withdrawal side effects, they may go back to the drug because they don't want to feel crappy when they're not taking it. And also they can develop a dependence, which is compulsive abuse and physical dependence. Range of withdrawal symptoms can be sudden discontinuation. Sudden discontinuation may cause severe depression or suicidal behavior, which is not surprising at all because if your brain is not producing dopamine anymore, it can cause a person to feel depressed and they may want to harm themselves. And so that doesn't surprise me whatsoever. And also paranoia symptoms. So when you're paranoid is that you feel like people are after you. You feel like, everyone's watching you type of paranoid feeling. All right, so let's talk about the medicinal uses of the amphetamines. And so it is used in Ritalin. And so Ritalin is used to treat individuals that have attention deficit hyper disorder. And so that these are people who can't sit still, they can't focus. So it blocks the dopamine transporters and basically just like ephedrine and cocaine. And so basically it just increases the dopamine. And for whatever reason, that's associated with the person to feel more focused and more relaxed. Then there's another type of drug called Psylar. Now, these are all drugs that are prescribed by doctors, and some of these are considered like Schedule 1, Schedule 2, because you need to have a special doctor to prescribe that for you, and you can only have a certain amount per every cycle, so you can only, let's say, get one dose of pills every month, like once a month. All right, so Psylar is a central nervous system stimulant, also used to treat ADHD. But I guess people don't use it as much because of the risk to hepatitis. To be honest, I don't know how it increases the risk of hepatitis, so my apologies for that. And it's also been used in pseudoephedrine, which I had mentioned earlier. You can find amphetamines, or I think it's ephedrine. You can find, so this is pseudo, like fake ephedrine. You can find ephedrine in cough and cold medication by prescription. And you can also find it in Sudafed, but again, you can only get so much to the pharmacist. Actually, I like using Sudafed because it's a great decongestant, and this is for when I have severe allergies, because I've had severe allergies my whole life. So when I'm really sick and my nose is clogged and I feel horrible, I do get Sudafed because it just works really good. But luckily, I only need to take a few, and in a couple of days, the symptoms are gone. So, I'm not in any way saying that it's not great for medicinal use, but of course, because of the highly addictive properties, it has to be taken only when needed or if needed. So if you have, ADHD, it's better to live life without it than, you know, not use a drug to treat your symptoms. So you always want to talk to a doctor anytime you need to use some type of stimulant. And then there's modafinil, also known as Provigil, and so also used as a psychostimulant to promote wakefulness and really to treat sleep disorders like narcolepsy or sleep apnea. And sometimes ADHD. So narcolepsy is when a person just falls asleep at any moment in time. They can't control that, and so it can keep them awake. And this other drug called Nuvigil is also the same thing for narcolepsy and sleep disorders, but this is in greater potency, so it's much stronger, and also used for jet lag. And so that means that if you go to another country and on that side of the world, it's nighttime when it's really in your side of where you normally are from, it's daytime, and so you can develop jet lag, meaning that you're still used to your old time frame, even though you're somewhere else and the time frame is completely different. So currently there are no FDA approved pharmacotherapies for stimulant addiction, but there are strategies. And so what I mean by FDA approved is basically there are no safe ways of doing it, but there are attempts with some pharmaceuticals. And the strategy is to block the euphoric feelings, and so a person can't feel euphoria when they take the drug anymore. You can try to reduce the withdrawal and negative mood symptoms and also reduce cravings. And this is done with several types of agonists. And so if you remember, an agonist mimics like what you feel when you take the drug. And so some of these agonists are amantadine, bromocriptine, L-dopa, carbidopa, and the drugs are called like bupropion, which is also known as Wellbutrin or Zyban. And you can also, try to use Ritalin and Provigil, since, they have the same effect as the drugs. But really, you're just replacing one for the other. So we don't know how, well of a treatment that is. And then there are other strategies which can be used to, or approaches, and I'll be honest, I mean, I got this from the textbook, but I'm not sure if these are already like available. But there's an approach to basically intercept the drug before it reaches the brain, and this is by metabolizing the drug with enzymes. And so let's say a person takes cocaine, and you have a surplus of enzyme that can just break it down right away, then you wouldn't even feel the effect of it. There's also another way, which is called the antibody method. And so this is designed to generate drug-specific antibodies that bind to the drug, for example, like cocaine, and prevent it from crossing the blood-brain barrier. And this is common for this is like a common way for other types of substances to not enter the brain. Proteins in the bloodstream will just bind to something else to prevent it from entering the brain. And so in this case, you can make an antibody like a protein, which is what an antibody is. It's a type of protein. It can bind to the drug, and now that molecule is so huge, it's so big, that it's very hard for it to enter the blood-brain barrier, because we know the blood-brain barrier is extra protective. And so if this molecule is huge, it's going to have a hard time crossing. And if it can't affect the brain, then you can't feel its effects. And there's also gene transfer technology, which is basically delivering enzymes by introducing a new gene that makes these enzymes at very high levels, and therefore the person who has this overly active gene to make a ton of enzyme will just break down the drug right away, and it can't affect the person. But I'm not sure, but I don't really think these kind of therapies are available. I think these are just like approaches to in the making, to treat addiction. But there is a cocaine vaccine, and so the cocaine derivative and recombinant cholera toxin B. It basically generates drug-specific antibodies that bind to cocaine and prevent it from going into the blood-brain barrier. And I need to do more research on this cocaine vaccine. I don't know how effective it is and if it's actually being legitimately used, but I think that's a very clever way to treat addiction, to be honest. All right, so this basically ends the lecture. Please, email me if you have any questions, or come visit my office hours. And you can also feel free to post up on the questions and answers discussion, so that way other students can help you answer questions that you may have, regarding the lectures or the study guide.